Okay, so this is a case scenario, very frequently asked. A 30 years old male patient presented to a pain clinic with a history of neck pain since last 6 months. So he has a history that 6 months back he was having a road traffic accident, and there was a collision with another car, and since then it was not a major accident, it was not life threatening, and since then after the accident patient was having the neck pain. So the neck pain initially it was responding to paracetamol and other NSAIDs. Gradually it is becoming severe. Neck pain is radiating up to the shoulder and little upper part of the arm, more on the right side, less on the left side. So movement of the neck is little bit restricted, and the pain worsens with the movement of the neck. So this is the history, short history. So what is the provisional diagnosis? So whiplash associated disorders or whiplash injury. So what are the differential diagnosis? Cervical facet, myofascial. Anything else? Up to shoulder. So it can be radicular pain as well, because up to shoulder means it is C4. So C4 radicular pain, or sometimes C5 also, partly by C5, but mostly by up to C4. So radicular pain can also present this way. What are the investigations you should do to confirm your diagnosis? So one of the investigation is, first is image. In the image always start with X-rays, and we are not going to supposed to get anything out of X-rays. In the MRI also will be likely to be normal. If it is whiplash associated disorders, MRI will be non-remarkable. Sometimes degenerative changes might be seen depending on the age-related degenerative changes, but whiplash injury itself normally do not associated with the major changes in the MRI findings. Sometimes it can cause prolapse disc, sometimes it can cause dislocations. These are the other parts, but those are rare. So here, according to the history, where the collision was mild, patient didn't have the major injuries. So here we are not expecting for the major spine fracture or dislocations. So here MRI findings will be almost normal. Then what else investigations? You can do the EMG NCB studies to rule out the radicular pain, and it again should come normal. On examinations, what are we going to get? Apart from the investigations, physical examinations, what are we going to get? One of them already I told that there will be restricted range of movement. Before range of movement, another important thing is inspection, it will be normal. Palpation, you are going to get the local tenderness, particularly over the facet joints. So whiplash associated disorders is a composite diagnosis. So here the most common thing is your facet joint. But apart from that, the myofascial pain, the prolapse disc, so these are the other components which might or might not be associated with the facet problem. But the facet problem is the most common thing. And what are the special clinical tests which might be positive? So one of them is Jackson compression test. Jackson compression test is you are rotating and tilting on the same side. The patient will be having neck pain. If the patient is having the radiating hand pain, then the same Jackson compression test is not only specific for the facet. it can also be positive in the radicular pain. So if it is going radiating towards the hand, we should interpret as a radicular pain. But if it is pain is limited to the neck pain, then it should be considered as positive for the facet pain. Same for the Sparling test. Sparling test is you are just pressing on the affected side, rotating the head towards the affected side. And what will be your findings? Again, like the Jackson compression test, here also the two possibilities. One is your local neck pain, which indicates facet problem, and another might be radiating hand pain. If it is radiating hand pain, then it is going in favor of your radicular pain. And if it is a local neck pain, that goes in favor of your facet pain. So there are a few other tests are there which you can do. Relief sign, the distraction. So these all also can be done just to rule out the other possibilities. So investigations will be otherwise not remarkable. Investigations will be mostly coming normal, particularly if it is facet pain. So as I told, the whiplash associated disorders where the pain is having the long course, most common reason is your facet pain. Other causes like myofascial or disc, myofascial normally it's self-resolving, do not last for the longer time. Though it's not a rule, but facet pain is most commonly having a longer duration. But majority of the whiplash associated disorders resolve spontaneously with the conservative management. Conservative management means the physical therapies, the simple analgesics. So these all can resolve the problem. But if it is having the long protracted course and not resolving with the conservative management, then you should think of doing an interventions. So in the conservative management, like other cases, simple analgesics, sometimes antidepressants, this can be added. And in the interventional management, what should be done? Medial branch block. Medial branch block or a medial branch radiofrequency neurotomy, depending on the level which is affected. If suppose C5-6 level is affected, so which medial branch should be our target? C5-6. If it was lumbar, L4-5, then L3-L4. If it is cervical, same. If it is 5-6 means it is 5-6. Because here one level up. So first, how to prepare the patient? Like we discussed earlier. So the preparation on the day of the procedure and preparations prior to it. So preparation prior to it what? That we will be doing all the investigations. All the investigations means the investigations to confirm your diagnosis or to rule out the other differential diagnosis. So here confirmation of the diagnosis is nothing. We have to rule out the other diagnosis, other possibilities, and then only we should be thinking of doing a facet joint. Facet joint diagnosis cannot be done with the MRI. Facet joint diagnosis should be done on the diagnostic medial branch block. So investigations means not to confirm the facet pain. Investigations to rule out the other possibilities, and investigations to see whether the patient is fit for doing the procedures. Means your routine test should be normal, there will be no signs of infection, total count should be normal, ESR CRP should be normal, coagulation profile should be normal, blood sugar should be well controlled. Diabetes is not a contraindication, but sugar levels should be controlled. So these investigations to be done, one to rule out the other possibilities, and second to look for whether the patient is fit for the procedure. Then what are you doing on the day of the procedures? Again the vital parameters should be monitored, and patient should be nil per mouth for at least 4 hours, a little more. The patient should be secured with an intravenous channel and then taken into the operation table. And here mostly it can be done under the two approach. One is patient on supine, another is patient on prone. If you are doing diagnostic block, then supine is okay. So here what we will be doing, we will be taking the serum on the lateral view. This is another procedure where the lateral view is the starting point. Like we discussed that the sphenoparietal ganglion block, lateral view is the starting point. So here also, if you are doing cervical facet medial branch in supine position, then the starting point is the lateral view. You have to superimpose the articular pillars of both the side, and then it should be going into the middle of the articular pillar, internal fission, and give local anesthetic there. But if we are planning for the RF, so you should do in the prone position. And particularly if you are planning to go for the lower cervical areas, you should start with the prone position. Why? Because shoulder will be obstructing your facets. So you cannot do the facet medial branch block below the C5 or C6 level because of the shoulder. So in those situations, you should start with the AP view. So the AP view, what will you see? You will be seeing the hills and valleys. So the facet joints will be situated in the hills, and the valley is where your medial branches will be there. The similar kind of things can be done also by the ultrasound guidance. So here there also you'll be seeing the hills and valleys. So hills where the facet joints are there. Intra-articular facet joints earlier was done, nowadays it is not done. Nowadays it is always the medial branch. So in the valley you will be seeing the medial branch. If you are doing on the ultrasound, you can see the accompanying blood vessels, and sometimes nerves are also seen. But if you are doing under the CM guidance, you should be into the valley. So if you are doing under the prone position, patient should be first lying on the prone position. CRM is focused on the arterially, and you should be looking about the hills and valleys, and your needle will be internal vision into the valley, touching the bone. Once you are going there touching the bone, then you go by the lateral view and see that you are in the middle of the articular pillar. So ultimately you have to go into the middle of the articular pillar. And if your shoulder is obstructing your view, what should you do? You should be doing a oblique position to see that you are in the touching, you have not crossed the articular pillar. This is very important. If you are crossing the articular pillar, then you are going into the dangerous area. In front of the articular pillar, all the important structures are there. So if you are keeping in touch with the articular pillar, then you are safe. And then diagnostic block, local anesthetic, not more than 0.5 to 1 maximum. And if it is positive, if the pain relief is more than 50%, then it is significant. If it is more than 70%, then it is diagnostic. If it is more than 50% but less than 70%, then you should do a dual diagnostic block. You should do the procedure another day with a longer acting local anesthetic. So the facet joint block, the dual diagnostic block is important. Dual diagnostic block must be done when the pain relief is more than 50% but less than 70%. If it is less than 50%, then it is negative. Then there is no need of doing another day. But if it is more than 70%, some literature says it is more than 80%, then also there is no need of doing in another day. But if it is in between 50 to 70% or 50 to 80%, then you should do the diagnostic block on another day with a another duration of. If you have done first day with the lignocaine, the next day you should do it the bupivacaine or ropivacaine. And if you have done the bupivacaine on the first day, next day you should be looking at the lignocaine. And what you should be looking for, that duration of the pain relief is matching with the duration of the local anesthetic action. Then only your diagnosis is confirmed. If suppose you have given the local anesthetic and the patient is enjoying pain relief you have given lignocaine and pain relief is there for the 10 hours, then it is not positive. Even if the pain relief is more than 80%. The reason is, so it can be having the false positiveness. Why false positiveness? Because facet joint pain, one of the important differential diagnosis is a myofascial pain. Maybe you have given injection in the myofascial trigger points. Maybe it is just a placebo effect because you have done something and patient is having the placebo effect. So the false positiveness possibilities will be increasing if your pain relief duration is longer than your duration of local anesthetic. And this is not uncommon. Many times we see it. We are basically breaking the pain cycle and the patient might be having the longer relief. But there you should be remembering always the possibilities of the false positiveness. So this can happen. And that is the reason why the dual diagnostic block eliminates the false positive of the diagnostic medial pain block. Ideally, the dual diagnostic block should be done in every cases, but unfortunately, most of the times patients will not agree just for the diagnosis. You are taking the patient 2 times in the operating room, 2 times you are doing the local anesthetic and injections, and then another day you will be doing the radio frequency. So majority of the times, it's very difficult to get the consent of the patient, and that is the reason why if with the significant pain relief, more than 70% pain relief, duration lasting matching with the duration of the local anesthetic effect, that should be considered as positive, and then you can go ahead with the procedure, just to reduce to increase the patient's compliance. Okay, so what are the steps I told you? The pre-procedural advice I told you. Now what are the complications of the procedure? Complications, always remember what are the nearby structures where you can go, what you can do, what you can damage. So nearby structures are nerve root, you can damage the nerve root. Nearby structure is your disc, you can go into the disc and you can cause the discitis. So these are rare. If you are maintaining the strict protocol of doing the procedures, these are rare, but this can still happen. You can go into the interthecal space, patient might be having the meningitis. You can have the total spinal anesthesia if you are going into the interthecal space. All these are the possibilities, but if you are maintaining the steps, procedural steps, these all are extremely rare. So for complications, always remember these things, that the short-term complications and the long-term complications, immediate complications and the late complications. Immediate complications are always related with the local anesthetic. Local anesthetic and sometimes particular steroid. Here we are not giving any particular steroid, but still local anesthetic complication is the immediate complications. So again, if it is going into the intravascular space, so there might be the bradycardia, cardiac arrest. If it is going into the intravascular space, these are the cardiovascular side effects. Neurological side effects of the intravascular spread, the patient might be sedated. But if it is a very large volume, there might be coma. But very commonly what happens, the perioral numbness, paresthesia, these are the very common things. And sometimes convulsion, but convulsion is not because of the local anesthetic, convulsion is because of the preservative with the local anesthetic. And that is the reason why all the procedures we should be always using, except for the skin infiltration, all the procedures we must be using the preservative-free local anesthetic. Only exception is when you are raising the skin, skin infiltration, there you can use with preservative local anesthetic. But any deeper structures, you should be always using the preservative-free local anesthetic. Then this complication will be limited. So these are the immediate complications. And long-term complication I told you, intravascular spread, having the neurological deficits, hematoma. So these are the late complications, infection. And what will be the post-procedural advice? Post-procedural advice is again similar. If the patient is having the intractable vomiting, if the patient is having any neuro deficits, any loss of vision, so all this indicates that either arterial spasm or some intravascular sprain which is going to cause some of the neurodeficits in the brain, because cervical area is very close to brain. So you should be always remembering that the cervical procedures, there are lots of cervical procedures reported with a stroke and death. So that is the reason why all the cervical procedures are considered as an advanced procedures. So you should be always be very cautious, and cervical procedures should be done only when somebody is very expert in the lumbar procedures. Otherwise, it's not that the cervical procedures are very difficult, but because the cervical procedures complications are dangerous, so cervical procedures should not be taken lightly, and there are lots of reports with these things. So immediately patient should be, first of all, before discharging, patient should be very nicely, carefully examined and observed at least for half an hour to 1 hour. And patient should be advised that if you are having this kind of symptoms, any neurodeficits, any weakness, any numbness, any loss of vision, any unconsciousness, vomiting, intractable vomiting, so these are the things which should be reported immediately. Convulsions, all this should be reported immediately. This is the post-procedural advice. Complications I told. So these are the things to be asked in the whiplash associated disorders. Okay, any questions?